Hi everyone, I'm Salena Williams. I'm the Director of the Services and Trusts Integrating to Improve Care in Self-Harm, the STITCH HIT. People may well have heard me say this before, but when we started a HIT, and it was going to be the self-harm HIT, we thought we ought to change it rather quickly. So our HIT as SIPIC has been going for more than 3 years, and so we've got a lot of experience to share with people, so please ask questions if you want to. Oh, what was that? There. Okay, these are our original aims. We wanted to make sure that people who came to A&E got a psychiatric assessment, because that's the NICE guidelines. Make sure people were trained up to understand what self-harm was and how to deal with it. Look at reducing, not the latest indications are that there's around 20 to 25,000 self-harmers in Bristol City alone, so we wanted to look at reduction of repeat self-harm in the city, reducing prescriptions of drugs in high lethality, reduced hospital admissions, and basically to reduce suicides in Bristol, because self-harm is the highest risk indicator by a long way. Self-harm is a behaviour which sometimes leads to suicide, and we wanted to reduce that. There are a number of quality objectives as well. So that's what we set out to do about 3.5 years ago. And what I wanted to do is just give you an example of one patient going into the A&E department and what happened to them then and what happens to them now, because it's been absolutely dramatic, and I hope people can see that. When a patient comes to A&E, and there's loads and loads of research about patients with mental health issues as a whole getting a poor deal when they come to A&E. If they came in the evening, there wouldn't be any of our staff there. They would have poor attitudes from A&E staff, and we have some evidence around that already collected at the beginning of the STITCH project. People were left alone, sitting around, didn't know what to do, didn't know what was going to happen to them, so they were absconding. They were leaving the department. There wasn't a mental health person there to give them an assessment, and therefore there was no follow-up. There was no leaflets, there was no resources. People didn't know what was happening, and so the whole experience of bright lights and people rushing around was made much, much worse by the fact there was no input to the A&E. So what happens now, and I wanted to try and make this one by one, but I couldn't work it out. I'm not very good at PowerPoint. Okay, so first of all, we've trained over 200 GPs in the Bristol area. And so if you go to GP surgery with self-harm, hopefully your GP will at least have some understanding of what you're talking about and what to do about it, and what local services are available to help you if you want to do something about it. Our prescription pilot is to a specific GP surgery in Bristol, and that's looking at people who may repeatedly self-harm and giving them smaller prescriptions. Now, this is against the law in England at the moment. It's legal in Wales and it's legal in Scotland, but in Britain you have to get your 28-day supply, and so lots of people who self-harm by overdose get their 28-day supply and take them. And so we were trying to think about ways in which we could make this work to make it more helpful for the patients. And so if you go to that specific surgery, then you will get that treatment, and we're assessing to see if that works. But it takes a lot of time, because you have to write the prescription in a different way for it to work. But we're also starting to do some other. Well, I've done some other work around the GP forums, and we're looking at ways in which we can help GPs to give a better service. We did a big, massive training day for ambulance crew, and so if you're picked up by ambulance, hopefully again you will have a person who knows what they're talking about. At the reception, we had a huge day, and I'll talk a bit more about that in a minute. At the reception, we've got a sign which says it's personal, because the self-harm patients told us there's a glass screen and you have to shout through it, "I've self-harmed," and that was really embarrassing and made people feel ashamed, because the rest of the reception could hear them. And so we've just got a poster which has been hugely effective and probably costs about 0.3 pence, but it's made a huge, huge difference to people coming to the A&E. We've got a massive project which is called the Self-Harm Surveillance Register, which records every single person who comes into ED, both at the BRI, at Southmead and the Children's Hospital following self-harm. And we've got a 40-item data set, of which a lot of our hit projects are based on. Also, if you come in and you don't know what's going on or whatever, the patients involved in the Stitch project made their own resource pack, and it's a really tiny Z card and it can fit into your purse and your wallet and so on, about what's going to happen to you when you're in the department and other help services available around, and what apps and what other things they can do to help themselves while they're sitting in the A&E to feel less isolated. So just coming in is a completely different experience, I hope. Okay, so if you're waiting for an assessment by a psychiatric nurse or a doctor, a psychiatrist, you used to have to wait. 50% of our patients did not receive a psychiatric assessment in the ED department. Because of the Stitches work, we got CCGs together, and we got a £300,000 financial investment into the services, and now we have 7 days a week, 7 a.m. to 10 p.m. to increase the hours at which people are able to see psychiatric help whilst they're in the A&E department. And as you can see, this has dropped dramatically and significantly the amount of time you wait to see somebody. Obviously, we're still working on that, and I'll go into the future plans as well. But this is just hugely, hugely different from what it was 3 years ago. Again, if you come into A&E more than twice with self-harm, you're approached, or your care coordinator in the community or your GP or whoever looks after you best in the community is approached to work with you to create a personal support plan when you come to ED. And so that's flagged up when you come to reception. And so staff who are seeing you have a greater awareness of what you want to talk about, how you want to sit, where you want to sit, all different details, but also who your care is in the community. And so they can contact people who can help you much, much more quickly. And that's working in across the two trusts, across Southmead and UH Bristol. So if you come to either place, if you've worked on a personal support plan, then that will be readily available for staff to help you best. All triage nurses and ED doctors are trained in mental health without exception now. We have a rolling programme, a 4-month programme, augmented by 6-monthly SPR training and an annual away day, which helps people understand mental health issues. And we have our PPI representatives coming in to deliver that training, which is just phenomenal. To have patients who have attended the department telling the staff how they felt to be in the department has made a huge, huge difference in terms of care. Okay, I'll go very quickly. The patients are also readily, easily available to be involved in research, and we've actually got a huge, wonderful research project going on at the moment in A&E, which gives patients who've tried to end their lives in the context of recession extra help at home. Another really small and really cheap thing that worked really, really well was giving GPs a little tiny box on the letter that they receive from the hospitals saying, this is the care that the person needs. Like, they don't need any further care, or they need this, or they need medication change. Just a tiny box at the top, because with 7.5 minutes, people need to know. The GPs need to know that crucial bit of information that's going to help that patient the best. So from that, I hope people will see that things have changed dramatically for patients who self-harm in Bristol, all across the city. We've got a load of stuff going on in the future, and I'll just, I've got 1 minute probably left. So I think one of the key things that we're going to be working with is there's a pilot of RMNs going into GP surgery, so how we can help them best. But there's loads and loads of stuff going on, and we're really excited still about it after 3 years. So hopefully that gives heart to new hits who are just starting out. It is fantastic, and it continues to be fantastic. Thanks very much.